We're going to start in about 5 to 7 minutes. Can I invite those of you who are seated in the back to come up in front, please? We will not bite you, we promise. So if you could just come to the seats in the front, we'd appreciate it greatly. Thank you so much for being here. Thank you. All right, good afternoon and welcome one more time on behalf of the staff of the Parliament and the Committee on the Joint Select Committee on Social Services and Public Administration. I'd like to welcome you to the second Town Hall meeting of the Joint Select Committee on Social Services and Public Administration and the Public Healthcare Services in Trinidad and Tobago. We are pleased to be coming to you live from the San Fernando City Corporation Auditorium, and we're happy to be in the second city of Trinidad and Tobago. I know Southerners will say it's the first city, but we're really happy to you all have welcomed us with warm, open arms here, and we thank the San Fernando City Corporation for assisting us in getting this consultation off the ground. Members of the viewing and listening public are invited to submit their comments and their questions on the Parliament's social media platforms, the Parliament's YouTube channel, ParlView, or via the Facebook and Twitter platforms of the Parliament of Trinidad and Tobago. I am the committee's chairman, Paul Richards. I now invite members of the committee to introduce themselves, starting with the Vice Chair.
Thank you, Chairman. Good afternoon, ladies and gentlemen. Good afternoon, members of the viewing and listening public. Roger Monroe, Vice Chairman of this committee.
And on my immediate left.
Yes, good evening, members of the public, listening public, and also those present. Esmond Ford, member of this committee.
Present, good afternoon, Chairman, members of the committee, members of the public, those viewing with us, members of the media, Member Mohit, a member of this committee, looking forward to fruitful discussions with you.
One of our members is on the way. Member Penelope Beckles will join us en route, and we also have another member who will not be with us today because he has a conflicting engagement, and that's Member David Nackle. We also have on the head table with us Dr. Sandy Arthur, who's a member of this medical association, who will be presenting a slight overview on NCDs. So I'll allow Dr. Arthur to introduce herself.
Good afternoon, everyone. Thank you, Chairman. And good afternoon to all those who are viewing as well. As said, my name is Dr. Sandy Arthur, and I am a medical doctor. And today I'm here to share just an overview of what NCDs are and to break it down for those who may or may not know. So NCDs, what does it stand for? It stands for non-communicable diseases. And really and truly, these are diseases or conditions where they're not caused by an infectious disease. They usually have some medical implication and require long-term treatment. There are many that we can talk about, but to give you a few examples, ones that we commonly talk about, diabetes, hypertension, but we also categorize cancers, mental health disorders, for example, depression, bipolar disorder, in this group of conditions as well. There are multiple risk factors. Some we can change and some we cannot change. The ones that we can change, or the risk factors that we can change, are what we call our modifiable risk factors, and the ones that we cannot change are non-modifiable risk factors. So let's talk about these a bit so we can understand our risk for developing a chronic illness a bit better. So non-modifiable risk factors, for example, we cannot change how old we are. We cannot change, although I think sometimes some of us may like to, we can't change our genetics, so we can't change our family history. However, there are some other things that we can change and we can modify, namely our lifestyle. So if we have an inactive lifestyle, we know that that is one that increases our risk for chronic illnesses. Our dietary choices is another big one. I think we've transitioned from the era of having persons who were undernourished, which in itself has its problems as well. And now we have a lot of overnutrition going on. I think that's a nice way to put it without calling other names. And therefore, with that has come a lot of the other challenges and problems that we are seeing. For example, increased risk then of heart disease, hypertension, and diabetes. Or use of certain substances, so for example, alcohol use and the use of cigarettes. These things are things that we can modify. Something that's up and coming in our society today is the use of these vaping devices. Persons would have seen it as an alternative to use of cigarettes and so on, but these come with its own inherent challenges and risk and lung disease. There's actually this emerging syndrome, EVALI, which is associated to the use of e-cigarettes and vaping devices causing lung injury. Weight is another challenge that we can work on, another modifiable risk factor. So now that we've gone through what they are, what are some of the risk factors for developing them, let's just talk a bit about how common they are here. So we know that they're common. Trinidad is no exception to the Caribbean, and unfortunately, they account for about 60% of our deaths annually. If we look at the top 4 conditions that cause death, or chronic diseases that cause death according to the National Strategic Plan for the Prevention of NCDs for Trinidad and Tobago, heart disease is number 1, 25%, followed by diabetes, which is 14%, cancers at 13%, and cerebral vascular disease, that's a big word for just brain vascular issues, 10%. So you can see that basically about 2/3 of our people die every year from some form of a chronic disease. So therefore, they should not be ignored. Why? Because they can not only impact the duration of our life, but they can also impact that quality of life that we have. I always tell patients that I see, no one wants to be in bed after having suffered, for example, a stroke. You're not able to eat the normal way because you can no longer swallow. You're not able to get up and walk. You're confined to bed. You may have your mental faculties intact, but you are dependent on someone to do everything for you. And I don't think that that is a lifestyle that anyone here would like to have to go through. So not just death, but also quality of life. So let's look at one of the common ones, hypertension, which falls under, it can have implications on your heart and the different vessels as well as your brain. So hypertension is known as one of these silent killers in the medical world. Why? Because you feel perfectly well, although your blood pressures may be elevated. So sometimes we just do a random check of someone and their blood pressure could easily be 200 over 100. And that's very abnormal. However, because our bodies learn to adapt and compensate in a big way, we oftentimes have no effects. We feel well, we go about our daily business. But just because we're feeling well does not mean that things are happening to our bodies. So with pressures at that level, you increase the work that your heart has to do. It changes the whole structure of the heart because the heart is like a pump and it's a muscle. And if it is forced to pump against such a high pressure, now your heart muscles change. They increase in size, and sometimes eventually they're no longer able to squeeze, or what we would call contract well, or they're not able to relax well. And that in itself can lead to heart failure. So a word to the wise, getting a check sometimes, random check, is good because a lot of these chronic illnesses fall into that category of being a silent killer. These conditions don't only impact the individual that may be living with this disease. Note I didn't say the word suffering, right? They're living with this disease. It can have a lasting impact on their family members as well. So if this person is the sole breadwinner of their home, they're now unwell, they're no longer able to work and earn, but that does not mean that the demands of the family have changed. They still need to buy food, they still need to go to school, they still need to pay bills. So therefore, when we have a sick family member, we can't just look at that person in isolation. We also have to consider what it does to the family as well, who now have to take care of the person who used to take care of them, literally, and still survive. And unfortunately, in our settings, we are seeing younger and younger persons being affected with chronic illnesses and now having to live with this chronic disease. If we really think about it, once upon a time, persons were diagnosed with things like, for example, diabetes, more so late 40s, 50s, 60s. And when I talk about this type of diabetes, I'm talking about type 2 diabetes, which is the more common one. So give or take 10 years and not controlled, complications would start. We would usually see persons with complications of diabetes more so in their 60s, 70s, 80s. But now we're faced with a position where we have persons in their 20s developing type 2 diabetes, in their 30s, sometimes even in their teen years. So if we have these persons and they're not being managed well, and we'll get to management in a bit, and they start to develop complications. When are they going to start to develop their complications? In their 20s, in their 30s, and their 40s. This is where people should be living in the prime of their lives, earning, working, and enjoying what life has to offer. But they now are faced with some of these complications. What are some of these complications? Sometimes, unfortunately, loss of limb, loss of sight, kidney failure, where you end up on dialysis. What are we going to do in the next 20, 30 years when we have an entire workforce where there's a potential sick member in about a quarter of them or more, and we have a family now that now has the older ones to take care of, the middle people who should be the buffer, they have to be taken care of, and then we have the younger ones. What are we going to do? So that just gives us an overview of, how important managing and highlighting chronic diseases is. So the approach to management for NCDs is no one-stop shop, it's not a quick fix, and it really is a very complex approach in that many persons are involved. And when I say many, everyone should be involved. It's not just a matter of health or Ministry of Health and doctors and nurses and the clinical departments and so on, but everyone is involved. I like to take a little page out of the elderly people's books in that they say prevention is better than cure, and that's the first thing I would like to say. Prevent, prevent, prevent. If we know what risk factors are and we can modify the ones that we can change, then we try our utmost best to do that. And when we do that, that's not just on the individual, but it's also to ensure that we have supportive environments for that as well. And sometimes it might mean that we may have to change our approach to how we deliver services as well. So that's one. Prevention is better than cure. Early detection. So sometimes we can't always prevent, but we can detect early. Detecting early is important and critical because it enables us now to ensure that we get in front of this condition, manage it well, decrease the likelihood of complications, and improve outcomes. So that we encourage persons, just as I would have said a little while ago, get your checks. Just because you feel well, don't let that lull you into a false sense of security, because as we've established already, a lot of these NCDs are silent killers. So we encourage persons to do their checks, visit your local health centers, visit your personal doctors, and you do what we call age-appropriate screening. And this is for things like diabetes, hypertension, the cancers that we have good screening tools for. You ensure that you get those things done appropriately and on time and routinely. Don't wait until you're feeling that pain to go. When you're feeling well, at least once a year, you go and you have a wellness check. And then last but not least, all of our other arms, so our families, our leaders, our policymakers, our social partners, civil society, each and every one of them has a part to play because they all impact the environments that we have to live in, grow in, play in, work in, and enjoy life in. So we all need them to be on board with us so that we can have those environments that support healthful choices. It's easier to manage a condition or to have a certain type of lifestyle when others are doing it as well and when there are the facilities in place for us to be able to do them well. And that is my bit on the overview of NCDs.
Thank you very much, Dr. Arthur. That was Dr. Sandy Arthur. I think we can show her some appreciation with a round of applause. She was able to give us a fantastic overview on non-communicable diseases, NCDs, so it sets the context for our conversation today. This town hall meeting is being held to provide the public citizens, you the citizens, you the taxpayers, with the platform to directly engage members of Parliament and with the Parliament of Trinidad and Tobago, with your representatives on some of the critical issues concerning the delivery of public healthcare services, because when you think about it, you, in my opinion, are the most important stakeholder of the Parliament because we serve you. So very often you see us in the JSCs in the Parliament building, so the Parliament thought it was a productive engagement to come out to you in various parts of Trinidad and Tobago, because you shouldn't always have to just look at us. You should be able to engage with us and give us your experiences and your feedback. It's an opportunity for you to share experiences having approached the public healthcare system at one time or another, either for yourself or for your family members or a friend in some instances, and also make recommendations for improving the public healthcare system. And healthcare is a broad and multifaceted area, so the committee has narrowed down its focus in this particular inquiry to 3 main areas, and they are combating non-communicable diseases, including diabetes, cardiological diseases, and cancer. Dr. Arthur spoke about the incidences of the deaths, heart disease, 25%, diabetes, 14%, cancers, 13%, and cerebral vascular diseases, 10%. So combating non-communicable diseases, NCDs, diabetes, cardiological diseases, and cancer. 2, the effectiveness of the Chronic Disease Assistance Program in your experiences, CDAP. And 3, the standard of service delivery at outpatient clinics in Trinidad and Tobago, but in this case we're in San Fernando, so I'm presuming many of you will also have interfaced with the system in San Fernando, but if you have interfaced in different areas, we also want you to share those experiences. On November 15th, 2023, the committee met with the management team of the Ministry of Health and the regional health authorities to discuss the state strategies for combating NCDs. Following the public hearing, the committee held its first town hall meeting in the parliamentary complex in Port of Spain on Wednesday, November 29th, 2023. So while we're empowered to do quite a bit of stuff and achieve a lot in joint select committees, there are some things we're not empowered to do that people may have misconceptions about. So we want to clear that up in this opening session. The committee is not empowered to provide redress or remedy for individual complaints. So we can't fix your complaints. We want to hear about them, right? As honestly and as clearly as you can articulate them for us. We do have the power, however, to hold the Ministry of Health and those who manage public health RHAs, the regional health authorities, accountable for their performance in your behalf, their policies, their procedures, their programs and initiatives, and if those programs and initiatives are working for you. And we are one out of 14 committees of Parliament appointed to scrutinize and oversee certain aspects of the work of the government of Trinidad and Tobago. The committee's work is not dictated by any political party or any political agenda. The mandate of this committee includes investigating and reporting on all matters relating to the management, activities, administration, and operations of various state bodies with focus on education, health, gender, tourism, public administration, labor, culture, community development, and other social services. So the committee's mandate is quite broad. And at the end of this inquiry, the committee will submit a report to the Parliament containing its findings and with your feedback included, and recommendations which will be sent to the Health Ministry and the RHAs for their attention and response, and hopefully to improve the delivery of service at the healthcare institutions, the public healthcare institutions in Trinidad and Tobago. Before we go on and start the official interface, let me just welcome Member Penelope Beckles-Robinson. Thank you for joining us, who's a member of the committee. We'd also like to acknowledge the presence of the Trinidad and Tobago Association of Retired Persons, the Cancer Society, and of course we heard a presentation from Dr. Sandy Arthur earlier on, right? In terms of our process, we will engage in a couple of broad areas. Let me just repeat them so that those who came in later on will understand. We're covering management of the public healthcare system in the first broad topic, and we're seeking your feedback on that. Secondly, access to screening. Third, access to treatment. Fourth, access to medication. Fifth, patient record management. And sixth, prevention and public awareness initiative. You'd have heard Dr. Arthur speak about the old adage, an ounce of prevention is better than 5 pounds of cure. So we're also speaking not only to treatment, but also preventative measures and how you think those are being promoted and if you're engaging in those in a productive manner, right? And when you want to make your contributions, and I hope you have a lot of contributions to me because this is about hearing from you, not necessarily hearing from us. We just like to ask you to move to the microphone, because we have 2 microphones there, and I will direct the order we will speak. You can identify yourself either by first name and a general area. Don't give your address, please. And if you'd like to share your experience or your information, as much of your information as you feel comfortable sharing. And if you're representing an organization, you can identify the organization that you're representing. And of course, we have some ground rules: respectful language, avoid using any insulting, obscene language, and keep your presentations as concise as you can while making them as clear as possible, right? So, are you ready to go today? How do they say it in the parties? Somebody say yay. Right, so ready to go today. We want to really thank you for being here with us today, because we appreciate you taking the time to interface with us so we can get your experiences. All right? And we'd also like to thank the San Fernando City Corporation once again for accommodating us, the Southwest Regional Health Authority, the National Infrastructure Development Company Limited, and the Public Transport Service Corporation. So we will start by moving to Member Vandana Mohit, who will start off our presentation on the management of the public healthcare system, and she'll ask you a couple of questions, and you will indicate your willingness to contribute to this. And you can contribute on more than one topic and more than one time. Okay? Member Mohit.
Thank you, Chairman. So I'll move to our first segment, which is management of the public healthcare system. Good afternoon again to those of you now joining us. So we want to speak a little bit about your satisfaction. Are you satisfied with the current management of the public healthcare system in Trinidad and Tobago? And before I give you the opportunity, in terms of the public healthcare system, there are 5 regional health authorities. We want to know from you as well, what are the main weaknesses of the regional health authority model in terms of the upkeep and management of healthcare facilities, the extent to which the management of the RHAs have been able to transform the quality of healthcare received at public hospitals. So I now give you the opportunity through your chair.
The floor is open. Anyone? Very simple. We're starting with, are you satisfied? Yes? Thank you.
Hello, good evening, everyone. My name is Darian, and I'm from San Fernando. Satisfaction would be moderate. This is a topic that's near and dear to my heart, because I think just like all of us, if not us being a patient, we know somebody who is a patient of the outpatient clinics. I myself have had to be a part of the lung clinic in the San Fernando General Hospital, and my experience was not the best. I know these clinics are trying their best because they are overrun with patients sometimes, but I think it's very...
Would you like to elaborate a bit? What was your experience like?
Yeah, so having to go to the lung clinic, you're reaching there, before 8, and you're waiting there until about lunchtime, and you get a number, but there's no guarantee you're getting seen by a doctor or even your information taken that day. And having spoken to the patients around me who were long-term patients of that clinic, they let me know some of them have never seen a doctor. They just keep coming day after day, getting their numbers and waiting. Or some of them were like, I reach here 6 o'clock in the morning on clinic days because I want to make sure I am the person that gets seen by the doctor. Because if I don't come at 6 and wait and get my number, I just don't get seen. I myself never got seen by the doctor. And unfortunately, I developed pneumonia and ended up in the emergency room. And that is where I got treatment for my issue. Thank the Lord, that doctor was able to diagnose me, give me the medication I needed. And it took about a year to recover from that, but...
So you left on the first day you visited, and you didn't see a doctor?
I didn't see a doctor, went back the next week, didn't see a doctor, went back. And then by that time, the pneumonia set in. And It's very scary not being able to breathe in the middle of the night and having to rush to the hospital.
So you didn't see any, did you interface with a nurse? Did they screen you at all?
They took my information, they took my x-rays of my lungs, and that was about it. Every day you come, you get your number, you sit down, and sometimes, in most occasions, there's not even seats for everybody. So you're just kind of standing up outside in the heat. So, you know, it's not something that, and not all clinics are like that, because I have family members who are part of the diabetes clinic and they have a better experience, but some of the clinics aren't being run properly, and I think it's because they don't have enough staff, because it felt like there was just one nurse trying to get everybody's information, and then when I spoke to the nurse, she said, well, it's one doctor. So, I mean, that's unacceptable for that to be the regular occurrance for that clinic. Now, this was in 2020, so I don't know if they got any better over the years, because I haven't been back. But that was something that really bothered me, because I was like, this is people's lungs, and they need to breathe. And if they have really chronic issues that they have to join a clinic, then they're not getting seen. That's dangerous. So that's my contribution today.
Thank you. I can see that it's still, I could hear the emotion in your
Yes.
voice. It really traumatized you.
It was scary, because feeling like you're not breathing and you can't get air and you don't know if you'll make it to the hospital, that's very scary.
Thank you for sharing. And I could hear that it has you very emotional.
Thank
and we'd
you.
like to thank you very much for sharing with us. Ooh, that one kind of hit me hard. Thank you so much. We really appreciate that.
Hello. After a lady, it's only fair it should be a gentleman.
Sometimes.
All the time. Right,
your
my
name-
name is Ronnie Roberts, 63 years old. I'm representing TAP, Association of Responsible People. I have some members with me here. For those of you who know, we are island-wide, and I am from the Princess Song area. I am satisfied. So sorry for the lady with her bad experience, but I am satisfied. I interact in two places, San Fernando Hospital, Heart Clinic, and up at Brothers Road. San Fernando, it takes me a day. So when I come in down, I pack everything and I walk with my this and that, and I know it's a day. Come in about 8, make sure and get my number, go upstairs, meet the people, and we good. I leave by about 2:30, but I normally get to see doctor, I get everything worked out. My CDAP working good. Harrow's, I could call people name?
Pens.
Harrow's Drugs in Princeton supplies us good, lovely. I interact up at Brothers Road Health Center. For those of you who don't know, that's very close to Harry's Water Park. That's our big claim to fame up there. Things okay with me. I make my clinic days. I take my meds. Last time I visited a couple of days ago, my numbers were great. Have a little problem with the dietitian, as you would see. And after Christmas and Carnival, we definitely would have a little fallout, but it's a work in progress. I don't have complaints, but I have compliments. I want to compliment the staff up at Brothers Road. They do a wonderful job. A great job. It's a great job. We go there. We see doctors everywhere. Every time I go there, I see a doctor, which is surprising. I mean, from the old days, you used to see the doctor, but every time I go there, we have a doctor, male, female. And I want to say thanks on behalf of my wife and myself. They're doing a great job.
What do you think has made a difference in your satisfaction? Because very often we had a conversation with Dr. Arthur earlier on, and she said it takes two to tango. So sometimes patients are not aware of what they have to work with, or sometimes they don't know what the procedure is. Is there something you think you are doing that has made the process satisfactory for you?
Might be my lifestyle. Might be my lifestyle. Yes, yes. I like people. I like to interact with people, and then I normally deal with people. I'm one of the kind of exemplars in the village. They had a male clinic the other day concerning the man problem. And you know, men, we don't like to go to the doctor. So I had to go through the village and call all my partner, hey, come down, let me go and check we numbers and that kind of thing. So that's the kind of role I play in the village area. But I'm still going ahead. We have even exercise classes up there. We have two wonderful ladies from the village, Margaret and Halima. once you're willing, you can go out and get a good workout every afternoon in the facilities up there. I have more, but I would leave it for a little later on.
Thank you. And
I
you
got
can,
some,
yes.
I finish it. I get some good information. This I promise to share it with my zone. We have 11 zones, my zone in TAP. Saturday would be our meeting, so I would interrupt the whole meeting and let them know what a wonderful thing we have here today. Thank you.
Before you, Mr. Chairman,
You go ahead.
before you go, Mr. Roberts, you said you involved with TAP,
Oh yeah.
and you talk about your relationship skills and how you like to relate to persons and things. And I'm thinking, is it as a result of you representing an organization that you probably are dealt with differently
No. I got good service before I represented TAP.
before you represented TAP?
Yeah.
Okay. But you are you are a long-standing service, you go to that particular Brothers Road.
Oh yes. My wife have been there for a while. I was a little embarrassed to go before I retired, so I used to hide. Because I was getting paid, public servant, so I didn't want to go and take up the facility. But after I retired, I joined the clinic and everything is running smooth. Yes, they do a wonderful job up there. Please let them know that. Tell everybody who's supposed to know, Brothers Road is running smooth. I don't know, something about the management, anything is available, they go and they get it for us.
But in terms of the numbers of persons on a daily basis, what sort of numbers, like when you go there,
Yeah, well,
the persons?
I would be on a Tuesday, general clinic, and yes, we have a 20, 25, 30. But I go in from about 9, 10. I don't do the early shift.
Right.
And then I would leave by about 2 kind of thing. So
And then when you do leave, is it that out of that 30 persons, they would have seen the doctor? How much of them may have seen the doctor and so on? And would have gotten attendance?
Yes, I tell you, we good.
All right.
We good, the doctor says.
I just wanted to
No,
be
I
sure.
tell you to compliment Brothers Road people and Brothers Road staff.
I
We
just wanted to
good,
be
we
sure.
good. The
All
doctor
right.
stays late. Everybody comes. Some people come the evening shift after lunch, and the doctor's still there. So I tell you, I compliment him, we good.
Oh.
So let them know that, please. Thank you. I may come back later on.
Ma'am, you wanted to speak? Thank you.
Good evening. Goes down? Okay. Yes. Good evening. Welcome to the South. When I read of your town hall meeting in November in Port of Spain, I felt disappointed that I had missed an opportunity to share my health experience, and I was hoping that you would come to South. So welcome. I am Shirley Sukraj. I have attended today in my capacity as legal guardian to a special needs relative who has Down syndrome and who unfortunately has been ravaged by COVID and is now completely bedbound. And therefore her challenges and mine have multiplied tremendously. And if I could share just this week's experience under your umbrella of management, on Monday, I had to shuttle between 2 clinics at the hospital here. The neurology clinic that my niece had missed last Monday because the transport had fallen apart. It was pre-funeral of the former Prime Minister, and so the transport issues were there. And I came to rebook. And I have a 77-year-old sister who's recovering from a mastectomy, stage 2 breast cancer. So I was accompanying her in the breast clinic. On that day, it was the first day of a change of outpatient management and policy and procedure. I think they're now introducing something called a block system where you're actually given an appointment time. Sadly, it's good the change is there. It is good that a system is being reviewed. It is good that new methods are being tried. I think what was totally absent was the communication with the patient, the recipient. Come 12 midday, my sister is still waiting to be seen, but we know that it's a clinic that runs late, and I'm waiting for a new appointment, and suddenly everything stopped. All the clerical staff are now going for lunch from 12 midday to 1 p.m. Now, if the service has changed in terms of extended hours, of course the staff have to eat, and that's perfectly acceptable. However, no one told the patients. And therefore, you had a long line of patients, elderly, infirm, special needs. The window was closed at 12, and they stood there for 1 hour until the staff returned. Had numbers been issued, because there were many vacant seats by lunchtime that could have been occupied, but people didn't want to leave the line in case they lost their place. And had numbers been issued to say, please take a seat, and when we come back, we will call you, according to these numbers, 90% of those problems would have been erased. Why I mention this is because of the people waiting to be seen was a gentleman with visible mental health issues. But he was very jovial, although active, overactive, but jovial. When the staff returned and addressed and stamped all the prescriptions, I saw him downstairs in the pharmacy. And he was very agitated, wanting to get served. But his agitation met an amazing response from a member of the security team who began shouting at him for speaking loudly, and her voice was thousands of decibels louder than his. And her reason was that this pharmacy staff is saying they can't hear, the patient's not hearing the name. But the point I want to make is the way this person with mental health was being treated so badly, so abominably cruel and humiliating, that I had to intervene as quickly as possible and decisively as possible to stop the verbal abuse. And to request the pharmacy staff, his number was 3, he was just 2 numbers away from his number coming up, if they could assist him by serving him and letting him go. And as it turned out, this gentleman had come from Icacus. It was already after 2 p.m. If you don't get to Point Fortin by 3 p.m. to catch that 4 o'clock bus to Icacus, if it runs, then that's your lot. And so it's that lack of awareness. And I'm not sure under which umbrella I share with you the problem with special needs patients. Is it under this umbrella of management, or is it access to treatment?
Not a problem. Go ahead.
Can I go ahead? Let me share this with you. I want to bring to your attention the existence of a policy, Southwest Regional Health Authority's policy, Care and Management of Persons with Disability and Special Needs policy. July of 2018, my niece was so badly treated, so insensitively. The care delivered was callous, cruel, insensitive. I was being told I had to leave her, vacate the ward, when she was on an A&E trolley receiving emergency blood transfusion in the middle of the ward. The location wasn't a problem. What was important was that she was getting the treatment. But here was the morning staff telling me I have to leave the ward. This is a special needs person who has been with no other stranger other than relatives since her parents died. And her relative is myself and another aunt. And no matter how much I tried to impress upon the staff that it was dangerous to leave her, if she doesn't see me, she'll climb off the trolley. However, moving forward, as a result of that awful incident that I brought to the attention of Southwest Regional Health Authority, I want to publicly thank them for formulating this policy, for getting a fantastic team together, for putting this policy together. But you know, the sad thing is, that was 2018. This policy was signed off by the chairperson, by the medical director, by various people. And if you go to page 11, each person, each head of department of Southwest Regional Health Authority is mandated to instruct their staff and sensitize their staff to this policy. To this day, that sensitization appears not to have been done because my experience as the caregiver, as legal guardian, as auntie, since 2018 is that every single admission, I have to walk with this policy as if it's my sword to say this is what she's entitled to. And there is total, almost total resistance from the staff to her right to have me stay with her. The reasons are amazing, you know. It's not fair to the nurses. You can't use their chair. If you fall down, what will happen? We can't have you here during the night. We don't have the facility. It is unbelievable that a policy exists and the staff are unaware of it. So if within your remit, this can be brought to the attention of Southwest Regional Health Authority, it is absolutely exhausting that every time she's admitted, I have to go through this. It is emotionally traumatic for her, and it is psychologically traumatic. Prior to COVID, she's functioned totally. All we needed to do for her was prepare her meals. She was 99% independent. COVID has ravaged her and turned her into a 100% dependable person. And I am at my wit's end as to where to go next, because each time she's admitted, I find myself knocking on the admin door, somebody in the admin to say, please tell the nurses this policy is in existence. And the response is that, well, you go with the policy and show them and tell them it's in existence. This should not happen. The Ministry of Health has a policy. Southwest Regional Health Authority have a policy. This country has signed into so many rights of disabled persons. So why is it the disabled patient is still suffering? There is no transport to bring her in. She's completely bedbound. Other than hiring a private ambulance, which is not affordable, I have to find a taxi driver willing enough to turn the back seat or a wagon, to turn the back of it into some kind of bed that I could bring her in.
So this is an ongoing challenge for you?
Yes, it is an ongoing challenge, Dr. Richards. Each time I come, the tension within me is that who am I going to meet? What resistance am I going to have? And even at the level of the doctors, you know, last Christmas we had to be admitted, and the response was, well, I've been here for 10 years and I've never heard of this policy, so show me where in the policy it says you can stay with her.
I want to thank you for
Yes.
sharing.
Yes.
And I know there are other areas that you may be able to contribute
Yes.
to in terms of your experiences.
Yes.
We appreciate your honesty
Yes.
and your
So
candor.
I
Thank you
just
so much.
wanted to bring this to your attention.
Thank you so much.
Yes.
Before you leave the
Yes.
microphone, may I just ask, how often do you visit in terms of the special needs person?
How often do
Do you visit your clinics? Or the hospital?
Yeah, we were not able to access clinics last year because we had no transport. We tried the disability center and their dial-a-ride wasn't working. We tried PTSC's El Damo service and only one bus out of 4 worked, and they started at 11, and I come from a village called Plock Road in San Francisco in Pinal. So although they were prepared to come, it didn't happen. So I could not bring her to any clinics. It is only this year I found a local driver with a wagon who flaps the back seat down. I went to an upholsterer and I got him to make me a transfer mat. I went to our local furniture maker to design a trolley so that I can slide her from bed to trolley into the back of the car. And that's how we bring her.
No, but Ms. Sukraj, I think what we want to really find out,
Yes.
when you have to take the person to the clinic,
Clinic, yes.
how often? Every week, every month,
no.
every...
No, she is in 3 clinics,
Uh-huh.
so it varies. She's in the neuro clinic, the cardiac clinic, and another clinic. It could be once a month, and she has not been able to access physio. That would have been more often. So at least 4 clinics. Mhm. And of course, the admissions in between, because post-COVID, she had many strokes. She's now unable to swallow, as you mentioned in your NCD with the strokes. She's waiting for a PEG feed, but they have no tubes in the hospital. And so she's on liquid and pureed feed.
So do you have any calls from the RHA or the health center inquiring about what is happening with your niece and providing some sort of connection for intervention?
After her discharge, she has had 3 admissions in the last 6 months, from December to now. There were calls, the Community Development Unit, I think it's called, but that didn't happen when it was sent out. So I went to Penal Health Center and a health visitor came home, but we could not get a doctor to come home.
Thank you so much. We appreciate your contribution. Member Mohit?
Just one additional question before we move on.
Yes.
You mentioned El Damo,
Yes.
which is a service provided for persons with special needs. Are you
Yeah.
aware that whether it's operational now and available?
I meant to have asked today in preparation for coming here, but no, I don't know what the present status is. But when I inquired probably 4 months ago, there was only 1 bus out of 4 working. And at that time, also the challenge for us would be that she may not be able to sit upright because she's completely bedbound and she's losing her muscle tone.
Sure.
So,
Thank you.
Yes.
Thank you so much. In the interest of time, you have a final question on management? And is there anyone else who wants to contribute on how they feel about the RHAs and how they're being managed before we move to our next overriding topic? Anyone else wants to make a contribution? Yes, please, sir.
Good afternoon, everyone. My name is Carl Ryan. I'm from the Claxton Bay area. I just I'm also representing TAP with some of my colleagues here. I'm a mental health consultant, and so I want to make a strong claim for the introduction of mental health training among the staff, hospital staff. But in terms of my own experience some years ago, I visited the San Fernando General Hospital with my ailing daughter, and we had to wait approximately 18 hours before we can receive treatment. And at no point any hospital staff came to say, well, look, we're sorry for the delay, but doctor will see you soon. No one came to reassure or to update us. Having worked extensively, both at St. Anne's Hospital and in the health system in England for many years, it then occurred to me that a lot of the patients visiting the general hospital, in fact the A&E, have mental health issues. And because of the culture of fear of mentally ill persons, the hospital staff sort of avoid dealing with these persons for fear of maybe they would be attacked or so on. But I believe that if they are trained to a certain extent, they will be more understanding and empathic and able to deal with the issue. In Trinidad here, what they do if such a situation occurs, they would call the security or the police who are not trained in any way. And I see that as a punitive step. So I think that in order to address the management of healthcare system, whether it's public or private or otherwise, there needs to be extensive training of all staff across the board in some sort of understanding of mental health care.
Thank you so much. Final call for anyone who wants to comment on the management issues at the health centers and the RHAs, opening and closing hours, accessibility to those. Anyone wants to comment before we move on? Okay, Member Ford.
Thank you, Mr. Chairman. Again, to keep in the same trend of thought, and the question is, have any one of you encountered challenges with accessing medical screening at a public health institution? If so, please tell us what were your experiences. All right, the other question, have you encountered a situation where a specialized doctor could not be sourced in the country to provide you with a diagnosis or a recommended treatment? Anyone along those lines?
So this area is focused on screening. If you've had challenges in those areas, medical screening as you have entered the healthcare system on first interface, and also possibly an issue with equipment and or specialized doctors. Has anyone experienced those issues in the audience? Yes?
Not so much a specialized doctor, but a speech pathologist for the swallowing challenges my niece has. The dietitian support is absolutely excellent, but there is no speech pathologist to assess her swallowing, and so that has to be sourced outside. So that is our experience.
Any requests made at the time?
Yes.
And what was the response from the institution at the time?
Well, I spoke only to the dietitian, and I was informed that we have no speech pathologists in the hospital, and that the only speech pathologists available are available privately.
Okay, and how long ago that was? What year? You could give
Oh, this is this year.
Oh, this is 2023?
Yes,
okay.
Because she got her strokes last year, so since the strokes. Yes.
Right. So if you've not experienced a challenge, would someone like to share a positive experience at screening? Because if there are no challenges, by implication, there may have been positive experiences, and we're trying to present a holistic presentation of what your experiences were. So would anyone like to share about an intake experience, please? Absolutely.
don't want to sound too positive, but last week when I did my visit, I have a, can't remember the name of the tablet right now, but the doctor who did the prescription, she wasn't a specialist, so she couldn't, she wrote it, but she couldn't do it. So the druggist informed me that I wouldn't be able to get that here, but I could go to Rio Claro, where the specialist would be there on a certain day to get the specialist doctor to recommend I can't remember the name of my
So
tablet.
you've got a reference.
Right, yes. But I'm trying to make the point that we're okay up there. And I hope you could say it so that it keeps coming up. Because I don't want the system to go down anywhere. I would like you, I see Mr. Ford laughing. If the people not complimented and they don't get the pat on the back and thing, they may start. Because I know other people have problems, but I would like our system to continue. Thank you.
You see, it's not that I'm laughing, but I'm sort of trying to put myself in your situation. And, you know, sometimes, again, the positive response can come and result as a result of how you approach the situation. And I'm thinking that you approach the situation differently, probably, as some others may not.
But my friend here is a consultant, so feel free to take me on as a consultant on how to approach this.
Anyone else wants to make a comment? Yes, please, go ahead, sir.
My own experience concerning my said daughter, who is deceased now, at one point, she had cancer of the endometrium. And the screening facility was not available at the time at the general hospital, so she was advised to seek that screening privately by the doctor, only to find out that the said doctor who said the screening was not available is the same doctor who provided screening in the private hospital.
Just to be clear,
yeah,
the screening facility was said to be not available in the public healthcare system, and you met a doctor there.
Available meaning the machine was not working at the time.
At the public healthcare institution?
Yes. Yeah.
But the doctor referred you to
a private health center.
Where she was operating?
Yes.
So he sent you to the private one?
Where we had to pay for the treatment.
Okay. That's what I wanted to be clear on.
The other issue is that, you know, the healthcare system, the state healthcare system is trying its best. But I think training again, staff need to understand that we're providing a product, which is a service, which is very difficult to measure. You know, a car is a product, a finished product, and you see a nice Mercedes and you say, I could see myself in that. You touch it and you feel it. But a service is a difficult thing to measure. But the only way we could attempt to measure that service is by listening to the service users, which are the patients. But if, you know, as patients always complain to me, I said, well, complain to the consultant. They said, no, they're going to punish my patient or my family. So I'm saying, in some instances, when patients complain, they may be seen as whistleblowers. So I'm saying perhaps we should eliminate this whistleblowing thing from the health service and allow patients to complain as freely as possible.
Well, can I make a suggestion? And I think you're making a very valid point. You're asking for a feedback mechanism in the public healthcare system that patients can say whether they're having a good experience or a bad experience and make recommendations in a structured manner. Is that what you're asking for?
Yes, and I think that exists to a certain extent. But patients would complain and they would not get any feedback.
Well, you see, complaining while you're in distress is one thing. Providing feedback in a structured mechanism is something else, because then you're in distress and a healthcare provider is trying to treat you. So I understand that that is one measure of feedback, but then there should be a general mechanism for feedback about service provision in the healthcare system.
What I would call a 360 degrees feedback.
Absolutely.
And so we need to try our best to eliminate, if possible, this punitive notion and ideation in the hospital where patients are afraid to complain because they don't want to be punished by the hospital staff.
When you make that accusation, have you experiences you can share about patients being, as you say, punished because they've made a complaint?
Well, the fear is there. As I said earlier, patients would complain to me and I would say, well, complain to the hospital staff. And they would say, well, no, I'm afraid that they will punish my patient.
So they're afraid of victimization?
They're afraid of victimization.
Thank you so much.
Yeah.
Member Beckles?
Thank you very much, Mr.
Thank you,
Chair. So I think the question I'm about to ask follows from the last issue that you read about feedback. So let me ask whether anyone has had challenges accessing treatment, whether it's dialysis, whether it's cancer, hypertension, and if so, please tell us about the challenges you experience. And have you had a challenge accessing surgical procedures? And also tell us what those challenges are. And the B part of that would be, have you encountered a challenge with accessing treatment or keeping appointments due to the lack of equipment at a public health institution or staff shortages? So can we have any response to those questions I just raised?
So this section is on accessing treatment, whether it be accessing the treatment itself for dialysis, cancer, hypertension, because those are the main areas we're dealing with, or surgical procedures, including delays if you get an appointment in 6 months or 2 years, or because we've heard stories like those, or any sort of challenge you've experienced in getting the actual treatment once you've been diagnosed. Does anyone would like to share an experience with that? As concerned, I know the young lady shared earlier on when she went in and she had the respiratory issue, and it's only when it was exacerbated and she was in extreme distress that she had to go in the emergency route. But have any of you had that sort of experience or challenge in terms of treatment? No? Go ahead, please.
Perhaps I can share my sister's experience as I accompany her. First, I want to compliment and commend the oncology unit. Her oncology care was absolutely superb. The treatment was the oncology to reduce the lump, then the surgery. Now, she'd had her 6 months of chemo.
So could you say which hospital?
Yes, San Fernando General here. And we were told that the window for the surgery was 2 months. That would be the best time for her surgery. That time came and went, and I began to be a bit concerned that we were not getting a surgery date. And when I was told that there were 18 people ahead of her, and they were doing, I think, 3 per week, and that there were a request had been made for extra surgery time, but that hadn't come forward. So of my own volition, I wrote to the hospital and I said, well, so much money has been invested in her, in the chemotherapy. Is there any possibility of accommodating her for the surgery so that at least she gets the benefit of the chemo and the surgery? And that happened within maybe a few weeks. So there was that initial delay, but she did get a surgery date and her surgery was done. Whether writing that letter made a difference or not, I would like to think it did, but that ability to say, well, look, something is not quite right, and let us alert you to it, that she was going beyond the 2 months where the surgery would have been at its best.
So can I ask a question?
Yes, ma'am.
Okay, so that you're saying the 2 months passed, yes?
Yes.
Okay, so how were you contacted for that? For the surgery?
No, I noticed that when we were attending the breast clinic, that ran parallel with the oncology clinic, And they had told us initially at the beginning that after 6 months of chemo, the surgery would be within the 2 months. And I was monitoring it. When it didn't happen, I kept asking the doctors, when would the surgery happen? So I was not contacted with a date, but after writing the letter, at one of the clinic appointments, we were given a date, and then I think 2 weeks later, we received a call to say there was either a cancellation but there was a vacancy, and they slotted her in, and the surgery was done. Yeah, thanks.
The young lady who spoke earlier on, would you care to share with us what your actual treatment regimen was like, even though you were admitted in an emergency mode? Because it speaks to access to treatment and type of treatment that you received. If you were satisfied, even though you had to be admitted in emergency mode after the delay in accessing services.
Okay, so when I went into the emergency room, I was seen about right away. They, of course, took my blood pressure and all of that, and they took me to be assessed by a doctor immediately. I kind of think that was because it was 3 in the morning, so it didn't have much people. They could have seen about me immediately. And then they put me on a nebulizer to open my airways immediately. After that, a doctor came in and asked me a series of questions. My mother brought my x-rays, and so he could have looked at those. And they gave me updated x-rays that morning, so he was able to make the assessment that it was resistant pneumonia, and he put me on a course of 2 different antibiotics and 2 different inhalers, all of which he said I could access from the CDAP program. That was another thing. I was able to get the antibiotics from the CDAP program, but they didn't have any inhalers. And that wasn't my first experience not getting inhalers from the CDAP pharmacy. And so I had to purchase those myself. And that was the regimen. I had to follow up. He told me, well, I could follow up with my local health facility in the next month to see how I was progressing, or privately. I went back to the health center, and from there I would get checkups every month, and it went every 3 months. But it worked, the treatment worked. It just took about a year for my lungs to get back to how it was before.
Based on some of the challenges that you referred to, has it in any way impacted on you wanting to access healthcare at the institutions? And that's for anybody else as well?
Yes, it has. I don't like going back to the health centers or trying to get public health treatment anymore, because it left a traumatizing feeling about the whole situation, and not being listened to a lot of the times, because it didn't have to reach to pneumonia, you know. But so most of the times I will see a private doctor. I haven't been back to a health center since then, so that's been 4 years now. Yeah, so I haven't gone back.
Anybody else wants to comment on whether any of your experience has caused you to be hesitant to go to the hospital?
And in particular men, because what the feedback we got in Port of Spain, well, men are generally less likely to seek healthcare screenings and interventions, because men are all free, we macho, and we can handle it and toughen up, and it will go away after a while. But that's not always the case. In fact, that's not usually the case, and that's why men have so many complications, because they wait too long. But would any of the gentlemen here like to share if the perception about the type of service that one may receive and the delays has impacted their decision to go for a screening or to go for healthcare? Would any of the gentlemen like to comment on that?
And can I add to that as well, to ask, when you're answering, and I know Mr. Roberts, you touched on this a bit, but do you believe that men specifically need to be encouraged, you know, in terms of accessing healthcare? Not only in respect to what you referred to, you know, you said you you go around in the village and you tell your friends, well, you know, guys, go and check up, you know. But do you think, from the audience, whether you feel a specific encouragement is needed?
Can I play school here and point out somebody and ask them for their experience? Would that be going overboard? He said, would you like to share, sir? The gentleman in the front row.
Or Mr. Roberts, if you want to
Or
follow
Mr.
up
Roberts, if
from
you want
what
to go
said.
again. Well, Mr. Roberts says everything is good, so.
Yes.
I love a mic and an audience, so.
Even if your experience has been good, because that's what you said,
Yeah.
have you had friends or family members, male, who have indicated a resistance to going for screening because they have felt, well, I don't want to go through that drama?
That's a serious problem, but we need to be gentle, right? Because all right, men claim to like women. We have an organization with plenty of women, and I cannot get my friends to come and join the organization. So that's the basic problem with men. But some of the way the professionals rush you, you have to be gentle with them and kind of coax them into coming across. Because yes, they know that they need it. When it's too late, I could give you a story with my sister-in-law husband who went straight up. All he taken is, forget the name of the tablet, and he said, he good. The day he left to go to work, all symptoms were terrible in a meeting. Everybody said, boy, you're okay. And he went home, reached in the yard, and that was it. And that was it. When we checked, he had not seen the doctor for about 10, 15 years. He was a senior position. He has medical available to him. And this is the basic problem with men. We just don't like, well, not we, they just don't like to do it. They just don't like to go there.
Do you think there should be a special public awareness program to encourage men to seek healthcare intervention screenings earlier,
right,
to get past that whatever it is that we feel we have to put up, as opposed to going to seek treatment if we have an ailment, or even on a general case to be preventative,
right,
you know?
Wonderful. And I would like to take this opportunity to let you all know that TAP is ahead of you all, so we're working on our gentlemen in the area, bringing them into the group and letting them know, well, hey, life nice, it's worth living, and these are the things that could help you stick around for a little while. So go to the medical facilities, go and have fun. In some of the cases, we mention it in meetings, gently.
Why do they tell you they're resistant?
I think it's cultural. Although I'm 63, but I think it's cultural because they believe in this strong macho thing. And I had a friend, he going to doctor, he just ponging up some bush and he drink that and he feel better by accident. And then he said, you see, it work for me, I don't have to go to the doctor. So I think it's a kind of cultural thing coming out of the era when we had the medicine home and the herbalists and that kind of thing. So, and then partly might be the cost too.
But they have no problem going to get a blue pill.
Green, not the blue.
Remember,
Yes, but I mean,
they have no problem going to get the blue
you know,
pill.
well, why take so long?
But
to
they don't want to
answer?
get other sorts of interventions.
Right, because I mean that's what we like how to say. So, but you see, don't stigmatize it. Look how you put that blue color to the blue pill, and yes, we all need
But
it.
it's a fact. While they will not go for other interventions, if they have diabetes, hypertension, or cardiovascular disease, and it has them feeling weak, if they have a problem in that department,
Right,
they have no problem going to get that sort of intervention.
which is easier said than done. All right, let's be real now. We have problems from a certain age up. As my brother would say, when you cross a certain age, your eye don't work good, this don't work good, that don't work good again. But you have to live with it. My father used to say, once you accept it, it makes life easy. So what you could have done at 35, what you could have done at 45, like I have a joke I just give, when you're 7, you stand up on the step and you're all day, so wee.
Okay. You know, thank you so much. I'm going to ask Dr. Arthur to intervene.
Before you go, I tell you all already, this is why Mr. Roberts get good treatment when he goes to the clinics.
Let me finish now. When you're 70, you have to make sure.
No, okay, right. But I think it's an opportunity for Dr. Arthur to intervene, because part of what we're trying to inculcate here is preventative medicine and wellness. And a lot of the issues that come about with both men and women are because they're not being proactive. Dr. Arthur?
Yes, I agree. It's like I said, it's a complex approach, and multiple things affect it. But yes, one is being proactive. We tend to, and I'll take your word, culturally we tend to react more. So we wait until we have an actual problem before we actually see about our health and wellness. And intentionally, I like to take things like health out of the equation and talk more about wellness, because when someone hears health, they generally think about being unwell. Whereas you want persons to be well, but still understand, because I am well today, I want to continue to be well. And therefore, there is a course that I need to take. There's a course of action that I need to take to ensure that I am as well as I can be for as long as I can be.
Right, but patience is needed. You don't talk to a gentleman Monday and expect to see him Friday. You talk to him the next Monday and the next Monday. You meet him in a little line and you talk to him gently. You see, some professionals feel that, all right, okay, come and do this Tuesday. And if you don't come, well, they're done with you. You have to go back.
And you are correct.
You have to check him out.
And I also want to commend you, because it seems as if you're being very active in your community and encouraging. I remember I spoke about we all having a part to play in encouraging wellness. So if more community groups did what you did in terms of going out and actively reaching out to your members and saying, well, hey, look, this is something that we can do, and you continuously encourage them, we should hopefully see more persons, both men and women, being more proactive about their health.
And we're trying to spread it through the TAP organization. While we're having fun, we're explaining. And February meeting, we're having a lecture on diabetes and that kind of thing. So you can leave me some numbers. I could call somebody to come and talk to us and whatever.
Absolutely. Thank you so much. Thank you, Dr. Arthur. Member Beckers, are you completed? Yes. All right. Member Monroe? Oh, please, just go ahead. Sorry about that. And then Member Monroe.
Observation is my job, is what I do. And my observation is that, and I never realized this until I worked in various hospitals abroad. Now, when a male doctor is seeing a male patient, they would require a female staff. When a male doctor is assessing a female patient, they would require a female staff to be present. Now, what we have when we're dealing with a male patient is sometimes a very junior person, sometimes a young female would be interviewing that male patient who might be 50 or 60 years old. So it will be quite difficult for him to give or to submit some of his personal details, because it's like talking to my own daughter. So what I'm saying is that male patients need special needs care. That is the bottom line, but special needs care in terms of how we approach them. Asking them to go and get your assessment done is like leading the horse to the water. Systems have to be in place so that when they go to the assessment center, they would feel comfortable and be willing to give of their information freely. So the system needs to be changed around to accommodate these male patients. Not all, but some of these male patients.
Thank you so much to understand the psychology of the male.
Yes.
Yes. Member Monroe, thank you so much.
Thank you very much, Chairman. Following access to treatment, my questions will come under the line of access to medication. Have you had challenges accessing prescription drugs at pharmacies at public health institutions? That's my first question. Second question, do you face challenges with accessing prescription drugs and or other pharmaceutical items for chronic disease assistance program, CDAP? And if so, can you share your experiences with us?
So has anyone experienced challenges? So even after you've been diagnosed with accessing medication? Good evening.
Good evening.
Mavis, I'm in a number of clinics and I have problem accepting eye drops. I'm in the eye clinic, and most time I 3 sets of drops I use monthly. And most of the time, if I get one, I get plenty.
How long have you been diagnosed and prescribed these eye drops?
More than 6 years now. I have glaucoma in the left eye, and I had cataract in the left eye also. I had surgery done to remove the cataract. The nerves in my eyes is damaged from the glaucoma, and I also have cataract in the right eye.
But I fully understand. My mother's blind from glaucoma, so I understand the importance of the eye drops to reduce the pressure.
Yes.
So have you?
I didn't come up before, but earlier this year I was also in the eye clinic. I did not see the doctor. I keep asking, did you all find my files? Have you gotten my files? And I was told, like, if you cannot hear, it means they find your files. I asked about the question about 3 times because I was there for an 8 o'clock appointment. And when about after 12 they came, they could not find the file. I said, if you all had told me that you all did not find the file because I was in the clinic December in the teaching hospital, it was GI, but they keep blaming it on the cyber attack on the system, and they did have my file in December. And again, about 4 months before I was in the eye clinic, they found my files, but I did not see the doctor. Just repeat prescription.
Well, sight is a very critical sense. And have you told your healthcare provider, your doctor, or the person attending to you that you are having challenges getting the medication, and that will have an impact on your prognosis, long or medium term?
Well, yes, they tell me to check our Superior Health Center or Princeton. When the hospitals, San Fernando General Hospital, don't have it. When I check Princeton recently, they didn't have, I think I got one. From there, they didn't have the other 2.
So if you can't afford it to buy it privately, you just can't get it?
Well, I have to make the effort to buy it private in the drugstore because it's not on CDAP.
It's not on CDAP?
No.
Oh, so if it's not in the hospital, you have to pay for it? Is it that there's a shortage in the hospital or a high number of persons accessing the eye drops? And I guess it's a limited amount of the medication available. Have they had that kind of conversation with you?
No, they don't have it. To check either Superior or Princeton. Superior Health Center might have one they don't have, but they might not have another. And same thing with Princeton.
Okay, thank you, Ms. Mavis. Just a follow-up question for information. At any point in time when you were unable to access those eye drops, were alternative medication recommended to you? And if so, were you able to access it at that time?
No, I either face the drugstore like
Okay, so
pharmacy.
in the public pharmacies.
Yeah.
So what is the status of your file right now?
Well, I knew they had it last month at the teaching hospital. It's just that at the old hospital, they said they couldn't locate the file. I'll know better next month when I go to
So in a case
New
like
Orleans.
that, anyone else is there anyone else with a show of hands having had an issue with their files or their case file going missing? You've 1, 2, 3, right? So I'll ask you first, and then I'll ask the other persons after, right?
Yeah.
So go ahead, Member.
Thank you, Chairman. My final question, and this is to the general gathering here. Have you or anyone you know faced challenges with shortage of drugs at the cancer treatment unit?
Can I ask?
Ms. Mavis?
Ms. Mavis?
Mavis?
Just one question before you leave the microphone. You've indicated that you are unaware as to where your file is at this point. When you were last told that your file cannot be found, what was indicated to you? Would you be contacted if it's found, or you are left in limbo until another clinic date?
I'm left in limbo until another clinic date.
So providing that they could not find your file, I'm just inquisitive to know, are you left with the same 3 medications that you indicated they gave to you to use?
Yes, but at that time they didn't even redo our next prescription because the other one was up. So I had the prescription on my phone. So they took it down and was able to do a next prescription until...
So each time you see the doctor, that's when you get your prescription to get...
Yes, it can last for about 3 months or 4 months. And so when the next appointment reach, I can't use the same prescription again until less.
So you are indeed in limbo.
Has anyone attempted to actually reinitiate starting a new file for you in the absence of finding or locating the old file, or trying to get your medical history to start a new file, because it's critical for them to continue your treatment?
Yeah, no, they haven't do that because I'm in 4 other clinics, so the files keep moving around. But I know when I was in the last clinic in December, they had the file.
When you say, is this a physical file or a digital file?
A physical file.
So if the file
so
is lost...
it moved from the teaching hospital to the old hospital and back.
Who moves it?
I guess the clerk to whichever clinic I have, they're supposed to...
So if you're at one institution and they refer you to another institution, they send the file?
Well, at least I think they could check it on the system. But, right?
I understand your frustration. Thank you so much. Member Ford.
You mentioned something that's very interesting. They keep blaming the cyber attack.
Yes.
So which means there's a digital file as well as a hard copy file existing for you. So if you are unable to find the digital file, you can find the hard copy. So they can't find either of.
Well, in the eye clinic, they did not look at the file. When I was in the other clinic in December, the beginning of December, they had the file. And I know the cyber attack was before that.
Okay.
Thank you so much. Member Ford.
Right, we'll keep on with regards to the same patient record management. Thank you, Ms. Mavis. I noticed 3 other persons identified with regards to like misplacement of medical records or files. Could you kindly share briefly, any particular instance that you should would like the committee to know what would have transpired?
Good afternoon. I was in the eye clinic. I was also a member of neurosurgery, GI, and orthopedic. Right. So I would go to, well, the clinics were over a period, right? I would go like every 2 months to a different clinic. I just giving you a broad thing. When I get to GI, I would go early and sit there. 12 o'clock, I go in for 8, 12 are still there. And when you query why you're still there, they can't find your file. And they would come with one sheet of paper and ask you questions and, well, we can't find your file, so you will come back next 3, 4, 5 months. Maybe we will locate it, go to another clinic, and it's the same thing. Once when I went to eye clinic, I spoke to I had eye clinic this month, and next week I would have one of the other clinics now. So I told the lady in the eye clinic, next week I have to go to, GI clinic. And she went up on the computer and she found the clinics, and then she say, I said, well, every time I go to clinic, they can't find my file. And she just got a paper, went onto the computer, and she put all my dates. And she stapled it to the front of the file, you know, to the front of the cover. She stapled it. She say, I will send this to let them know where your file have to go next.
Now tell me something. These 4 clinics are in the same building?
Some is in the teaching hospital, the eye clinic is on the other side.
Okay, on the other side.
Right.
Okay, okay.
So, but it's the fact is that every time you go to clinic, you're sitting there for hours and they can't find your file. So after a while, I started to say, I will tell, when I carry the file back to the front, I will say, next week I have to go neurosurgery, eh?
And
or
once,
next week I have to go GI, eh?
And then once the file is not there, you cannot get no treatment?
No
treatment?
No, because they can't find the file.
Okay, so that's something, Mr. Chairman, we definitely have to pick up.
Please,
Thank
please.
you. Thank you. Miss in the black and white stripe, you care to share any situation you may have had?
Hi, good evening, everyone. My name is Luan. I am involved in a neurology clinic. And the same thing happened with me sometimes. They can't find your file. When I go in, the doctor asking me, what is your name again? And how old are you? And I said, but doctor, all it is, he said, no, man, this is a new treat we are making out for you. We cannot find your file. Once the doctor know my situation, he will put whatever he wants or whatever he know is for my situation. I said, but doctor, I have weaned myself off of that. Since the pandemic, I say I am no longer on that because I wasn't getting it. Okay, I saw it kind of mysterious when I say in my situation. I'll be open with it.
You're referring to an actual physical file, an actual document?
Yes, yeah. So he will.
And how often this would have happened with you in visiting?
I have weaned myself over that. I said, no, I don't want that medication. Or again, after weaning myself off it for the whole entire pandemic, I wasn't getting it. So I have weaned myself. They're writing one thing over and over and over and over again. That's it.
Okay.
So what is the status? So you're no longer receiving treatment? Is that what you're saying?
Yes, I am receiving the treatment now.
So they've given you an alternative prescription?
Yes, I get prescription.
And what is the status of the file now?
Well, now they have my file because they made over a new file.
And this is a physical file or a digital file?
A physical file.
Thank you so much.
The gentleman in the blue had his hand up also.
Gentleman in the blue, you had a comment about file management.
I think all this is tantamount to poor patient's record management. And it's not so much to blame the hospital staff, but it's the system that we have in place. Sometimes the quality of the material that the notes are written on, dog hairs, piece tear off here, and some pages missing and so on. So the quality of the paper is poor. Also, the labeling on the cover of the file, there should be clear labeling that could always be visible at all time. And I think, hospital staff, including doctors, should learn to apologize when they get it wrong. I'm sorry, but in my own situation with my daughter.
That may be a situation where they're trying to avoid liability. So that may be a challenge. And I understand what you're saying in terms of an empathetic approach.
Yeah.
But I could understand from that side of it that, well, I'm sorry I got it wrong, I misdiagnosed you, maybe have a different outcome.
Well, not so much misdiagnosing, but the file is
service
misplaced.
The service. Okay.
Yeah.
Thank you so much.
Okay.
Dr. Arthur, would you care to comment on what the present status is on file management? Is it paper-based? Is it digital? Is it hybrid? Is it a process where we're transferring to a digital database?
So I can't comment on that fully, but I can tell you what exists in terms of general terms. So medical records, you have one file per patient. It's important that you have all of your medical information in one place. From listening to the comments that have been made, when persons are in multiple clinics, it seems that that is where they then have a challenge, because they may be in one clinic this week, but not all of the clinics are necessarily in the same place. So then that file has to actually be physically taken to the next destination, right? So there is that challenge. Yes, there is also moves to have digitization, but of course that is a process, and over time, the persons who can speak to that should be able to give us an update.
Thank you so much.
Mr. Chairman, just one
Yes,
additional
sure.
point to Dr. Sandy. And within the whole medical field, is there a position, an occupation of somebody's being responsible for taking that file from point A to point B? Who has the responsibility for ensuring that that file gets from AI to oncology or the eye clinic, as the case may be?
So hospitals will have a health records department. So there is a department that oversees the management of the health records.
And that will have to be done on a timely basis, because if I'm seeing the eye specialist today, and I have, as the lady mentioned, she has to go to the other neurosurgeon the next week. That have to happen within that particular period in terms of ensuring that that file gets to the different department on a timely basis. And I think this is where the delay comes in.
But the issue, the overall mandate of this committee is also to find out the inefficiencies of the system, and if there are those mishaps and miscommunications and ineffective coordination, it is affecting the level and the standard of care that the patient is getting. Not only is it going to potentially put the patient in a position where the timely intervention is not made, but there's also an emotional component to that, where the patient is also further distressed by not having the kind of care they want when they think they should have it. So I think that is also part of the challenge being faced here, because it exacerbates one's feeling in that moment of distress. So I think, and that's why the feedback is important. Yes?
If I may just add, the issue of the missing files creates other problems, particularly with the medication. On Monday, when I went for the repeat appointment, the next appointment, I had the prescription with me, but there was an error in the thyroxine, which I had asked the pharmacist to write a note at the back so that I can bring it to the doctor's attention. When the new prescription was written, the error was repeated. And had I not had the ability to read the prescription and see that the error was repeated and ask the staff to resubmit the prescription to the doctor, let the doctor look at the pharmacist's note and correct the dosage, that would have not been corrected. So if the patient doesn't have that capacity, that ability, that experience to know that something is wrong that needs to be corrected, or even to remember their medication, the majority of patients would remember their medication by the color of the medication. They would not necessarily remember the name. So if they do not have the prescription with them and their file is missing, they are at a complete disadvantage. By the care cannot continue smoothly. And also, if they are not able to give a history, as my 77-year-old sister and my niece with Down syndrome can't, then again, it's a double disadvantage, because without the file, no doctor would remember everything about each patient. They can't. So the presence of the file is crucial to getting the most out of that encounter.
Thank you. We're running short on time. We wanted to have this completed by 7 p.m., which leaves time for one more section, which is the prevention and public awareness initiatives. Member Vandana Mohit, and then we'll go through if there are any comments that any of you want to make in closing, so we can end today's proceedings. Member Mohit.
Sure, thank you. Quickly, I know some of us touched on it already in terms of public awareness initiatives as we spoke about the men. So our final question here would be, are you pleased, or do you think enough is being done to educate the public about NCDs, and whether there's adequate information available on NCDs, meaning cancer, diabetes, etc.? And additionally, have you attended a health and wellness event or any health and wellness event recently held by any of the RHAs?
Floor is open. Public awareness. Anyone can comment. Are you satisfied with the level of public health and awareness initiatives under the Ministry of Health or the regional health authorities? Have you seen advertisements? Have you seen public service announcements talking about NCDs? Are you getting the information you need to make the decisions about your lifestyle choices? Do you think it's adequate?
I don't know, but I think there is a budding sense of public mistrust with the health system. They see stuff advertised by the RHAs, but for some reason they are hesitant to get involved. This might be harsh, but a friend of mine was really suffering with intense diabetic condition, and I said, well, you know, why don't you go to the hospital? And in a frightening tone, she said, no, there are skilled people in there. You know, so it gives you an idea of what is going on. But I feel that the RHAs and the health systems and the advocates needs to market themselves more. I don't think it's effective whereby you just post an invitation and people would run towards it. Because there's already a culture of fear and mistrust going on between the public and the healthcare system. So I think the RHAs need to embark on a consistent marketing program where they would go out and meet people in the community.
Should that marketing campaign also include what services should be obtained where? One of the bits of feedback we received from the management officials of the RHAs is that very often people go to the accident and emergency when they can go to the community healthcare center, and that clogs up the system. So people are not clear sometimes in what services they can go to for in what area, and make the process much more efficient.
Exactly, exactly.
So you agree with that?
I agree, totally agree. I mean, when I lived in England, you know, friends were calling me, asking me what to do, where to go. So it's not very clear, you know. So there needs to be more consistent education. You know, Allah could no longer go to the mountain, so the mountain needs to go to Allah. So the healthcare system needs to come out from its basis and go into the community. I would also like to suggest what we call mystery shoppers, meaning that senior managers should take time to walk around the various clinics and wards unannounced to get an inside view as to what's going on. It's amazing what they would find. Because in terms of the management of patients' file, while you may have a hospital system in place, who actually physically takes this file from point A to point B, and most times it's healthcare assistants who don't have a clue of what's going on. Sometimes they can't remember the patient's name, they can't understand the name, the files are in between and around, you know. And filing is a specialist intervention where you need trained person to manage these files and transport them from point A to point B and then return them to their sitting place.
Thank you.
Yes.
Member Mohit, and then Member Manura, Member Ford, and then we have to wrap.
Yes, quickly, in terms of awareness programs, the Ministry of Health would have had, certain programs launched, such as TT Moves, Water Wednesday, Fruit Friday, Shape Up Saturday. The RHAs would have health fairs and caravans, you mentioned, going into the communities. The wellness festivals. Have you had that opportunity to experience any of these any of you in this crowd. And in addition to that, before you go, do you have any suggestions as to how the government or the Ministry of Health can improve on their strategies as it relates to these particular initiatives?
We at TAP, we're lucky because we went to the TT move. And, well, I didn't come with a medal. We walk around with the minister and we got some medals and things, and we had a good time that day. So this is what TAP would do for us. Like today, TAP called yesterday, tell us this happening, and we come down. So we kind of lucky. But if you all could change some of the ad characters, you have been seeing some faces advertising for you all, and it ain't working. People ain't coming out. So try some new people, some different people in your ads coming up, if you understand what I'm saying. Because you're using the same actor, the same voice for about 10 years, and according to my friend, the people don't trust the voice because the voice and the people kind of align to each other. So we could get some new people, some different people, and that kind of thing. We up there okay again because we get, you see.
I'm tempted to say this.
Go ahead, Tim, go ahead.
This town hall meeting brought to you in part by TAP.
Well, this is what TAP is about.
I feel we can recommend to use it, Mr. Chairman.
Yes, I mean, at a reasonable fee, but this is what I'm about, and I'm willing to go on TV to let people know and to talk, because, I mean...
We appreciate your advocacy, because it's not all bad news.
No,
painting the
no, I will be doing on the good side.
Thank you so
So we
much.
can have two.
Anyone else wanted to comment on recommendations?
Well, just to say to Mr. Roberts, so you're saying the messenger is as important as the message. Got you.
Yes.
Maybe just to comment on accessibility, the TT Move wellness event that is going on. Last year, lots of banners were put up in both the teaching hospital and the general hospital. But the banners are like 40 feet high. If you walk down Chancery Lane, the banner is 40 feet high. A lot of money has been invested in putting information that nobody is reading. And so perhaps some thought needs to be given to bringing it nearer home at ground level, whether it is you use the foyer, or the entrance foyer of the hospital, you walk into the teaching hospital, and there is no ambience of wellness. So perhaps we need to change the perception of hospitals. We don't just go there because we are ill, we go there to get better. And that welcoming ambience, perhaps a lot of there are lots of leaflets, thousands of leaflets. We have lots of leaflets here too. But is that information getting to the average person? And you know, if we wear the shoes of the person who cannot read perhaps, or maybe use the schools, you know, educate the children so they can take the information home. You have a community that is not digitally, I'm an oldie, I'm no good with these things. So the little ones will come and help me. And perhaps if we could send the message through the school children, you know, the ones who can go home and have a conversation. Well, why don't we put a fruit in the lunchbox? Are we getting fruits with the hospital meals? We need to teach what we are saying and not just let it be words on a piece of paper that is nice and colorful, so that the message gets home. It just occurred to me, I saw the scaffolding going up outside the teaching hospital and thought they were repairing the wall. And then the banner went up and the scaffolding came down. And unless you know there's a banner there, you're not going to look 40 feet up in the air. Just tell you that, you know,
So you think
drink
it's
water, TT moves.
Poor placement.
Yes.
Thank you so much.
Yes.
Members, any other questions as we close? Member Ford?
Yes. Mr. Ryan, you willing to share with us your years of service within the health industry?
If I share that with you, you would calculate my age. But, you know, I worked at St. Anne's Hospital for 23 years, so I practically know it inside out. And then I spent another 25 years in the health system in the UK, where I was involved in several sounded board committees, did lots of research. My research work helped to change policies in the NHS in England. I've been throughout Europe sharing my research and contributing to cutting-edge psychiatry because my specialist area is in psychiatry. My other specialty is conflict management, where I trained Met Police, prison officers, hospital staff, psychologists, school and university staff. In fact, training in conflict management is mandatory in England.
Final question.
Yes.
You said you're a consultant. Any services you provide for us locally here in the health ministry, the RHAs, the health centers?
Well, that's an interesting question, because from approximately 2005, I've been trying to make contact with the health service, national security, schools, to share my knowledge and experience without any success. But at the moment, I've got an NGO. I've established an NGO, which is called NICER Foundation. And every October, World Mental Health Day is the 10th of October. So I would host a week of mental health activities on the pavement over the road there. That's from about 2013 up to about 2018. The COVID sort of put a stop to that. But yes, so I provide assessments and counseling and referral for patients. And that is on my own steam. What I realize is that, and I work independently, the problem we have in psychiatry, because that's my specialist area, is that the persons who need it most can't afford to pay. So I provide a service rather than demand a fee.
We thank you so much for your contribution. Give him a round of
Thank
applause,
you.
please. But I calculated your age, 23 and 25 is 48. So starting at 20, it put you at 68, and at 5 years retirement, put you at 73.
I think he over Roberts. I think he put Roberts.
So I did some quick calculation. Thank you so much. And we'd like to thank you all for your contributions and your presence here today. We really appreciate your taking the time to be with us, because what we're trying to do is outreach from the Parliament to find out what your experiences are in various inquiries that we're doing. So we really appreciate you taking the time to come out here. We'd also like to thank the committee members for their continued support, all who are here today. We'd like to thank Dr. Sandy Arthur for being with us and doing that presentation on NCDs. And representative of the various NGOs, let's give a round of applause to TAP. The San Fernando City Corporation, the Southwest Regional Health Authority, National Infrastructure Development Company, the Public Transport Service Corporation, and of course we could not do this without the support of the office of the staff of the Office of the Parliament of Trinidad and Tobago for your procedural and logistical support, and of course the tech crew and all who drove down to San Fernando with that highway being fixed there. So we give them a round of applause, please, because we could not do this without their support. And the viewing and the listening audience is looking at the chat a while ago. It's quite fervent, and people are sharing similar experiences at various health institutions, both good and both with challenges. So it's important for us to get the feedback to put into our report so that we can hopefully make the healthcare system and delivery of services better in Trinidad and Tobago. The committee's next town hall meeting will be held on the 1st of February in the borough of Chaguanas. So we've had one in Port of Spain, we've had this one in San Fernando, we'll be going to Chaguanas next. So persons who reside in central Trinidad specifically, and from all over the country, because we're inviting everyone, are encouraged to attend on that day once again in Chaguanas on the 1st of February. On behalf of the entire committee and the technical staff of the Parliament and staff, we thank you for viewing and thank you for being here. This meeting is hereby adjourned.